Kia ora koutou, ko donoho. This session reviews the ECG characteristics of a bundle branch block. They can interfere with the aspects of ECG interpretation and specifically with that of ST segment elevation. They're likely to produce a STEMI mimic, and recognising the block may prevent undue concern for all involved and unnecessary treatment or cath lab activation. Of course, not all wide QRSs are caused by a bundle branch block. Here we have a short list of likely culprits. Essentially, it's a differential list for the cause of wide QRS complexes. The thing we have to exclude on this list is the rhythms of ventricular origin. The next most worrying occurrence is an electrolyte or some other form of metabolic disturbance. These also have worrying outcomes if they're not corrected. Now, spotting these is covered in a different part of the program, but I'll just mention that the differentiation is an important step to make. If you've excluded the rhythms of ventricular origin and these metabolic disorders, the next step is to consider a bundle branch block. If this is the case, the block can be classified as a left bundle branch, a right bundle branch, or an indeterminate ventricular conduction defect, otherwise known as an IVCD. The last consideration is whether artificial pacemaking is responsible. Ventricular pacing is normally achieved via a pacing wire placed against the intraventricular septum. Its placement avoids the bundle branches and is most likely to replicate a left bundle branch block. So there are three basic principles that we need to stick with. The first is that a bundle branch block can only be assumed in the presence of a supraventricular rhythm. In other words, if there's no P wave that's associated with each of the QRS complexes, then we can't be thinking bundle branch block. The second basic principle is that any bundle branch block is going to slow ventricular conduction. So if there's no widened QRS, there can't be a bundle branch block. And reassuringly, when it comes to the differentiation of bundle branch blocks, there are really only three leads that we need to have to consider. We're going to look at lead 1 and lead V6, the left-sided leads that are going to show a similar pattern. And what we're going to do is compare that with a right-sided lead, in this case V1, to make the final determination. From a comparative perspective, I was just going to start with what happens during normal depolarization when the bundle branches are intact. From the red arrow, you can see that normal septal depolarization commences on the left side of the intraventricular septum, but spreads rapidly towards the right. That's the small red arrow. Thus, any right-sided lead, such as V1, is going to see a positive deflection, one that we would normally call an R wave, while the left-sided leads see this moving away from them, and so they're going to see these small negative deflections that I've marked out here in red. The next phase sees the left and right ventricles depolarize almost simultaneously, and the predominance of the mass in the left ventricle means that left-sided leads such as V1 and V6 are going to see massive positive deflections. So you can see those in the light blue. And because V1 is on the right side of the heart, i.e. seeing it from the opposite point of view, it's going to see a large S wave. So a bundle branch block is a condition that's going to prevent the depolarization wave from completing its journey down the right or the left bundle branch. If this occurs, the depolarization wave is going to exit the site of the blockade and then create a slower depolarization sequence using the myocyte to myocyte system. So this is much slower and the QRS duration will be longer. So depending on which of the bundle branch is blocked will depend on what the QRS will look like. We're looking at the right side of blocks first. Now the early depolarization of the left side of the septum moving to the right is unaffected. And likewise, the initial activation of the left bundle branch happens just like it would normally. And so the early part of the depolarization sequence is largely unaffected. The early part of the wave and all of the three leads we look at is still going to be less than 0.4 milliseconds. The block in the right bundle and the slower depolarization of the right ventricle is going to delay the depolarization of the right ventricle. In the meantime, the polarization on the left is electrically unopposed, and this is going to cause a large positive deflection in the left leads. So we're always going to be looking to see large R waves in lead 1 and V6. However, this delayed depolarization of the right ventricle causes a slowing of the terminal phase of the S wave. Essentially, the later bit is taking longer. In addition to this, the late depolarization of the left ventricle causes a biphasic component to the latter part of the depolarization cycle. Most simply put, this is the traditional rabbit ear type morphology that we see in lead V1. Let me recap. The hallmarks of a right bundle branch block are a QRS greater than 0.12 of a second, predominant R waves in lead 1 and V6, and a slurred S wave in 1 and V6. And then that biphasic pattern, that lovely rabbit's ear pattern that we're going to see in V1. Now there are several variations on this rabbit's ear pattern, and you can see all of them here. But the one thing that they all have in common is this bimodal appearance of the R wave. So there's a small R wave that's representative of that normal early depolarization, and then the second R wave arrives late in the cycle because of that slow depolarization of the right ventricle. Right bundle branch block is not normally a concerning finding. It's most associated with age or the pathology of aging with fibrosis, and it can be associated with pulmonary hypertension, and that is common in the setting of COPD or right heart failure or valve issues that affect the right side of the heart. In acute settings, a right bundle branch block can be caused by right ventricular overload, and this can occur with, say, a pulmonary embolism. With ischemic cardiogenic findings, it might be associated with a septal AMI, and should you see a pathological Q wave in V1 and a right bundle branch block, this is considered to be diagnostic of a septal AMI. In other settings, where an acute myocardial infarction can't be ruled out, the presence of a right bundle branch block does not alter the index of suspicion, and the presence of the block doesn't alter the recommendations or management we would have during an encounter with someone who's got undifferentiated chest pain. In other words, we follow the basic principles of treat the patient and not the monitor, and that all chest pain is cardiac until proven otherwise. Now this brings us on to left bundle branch blocks. So a blockade of the left bundle branch slows and disrupts the usual depolarization of the septum itself. So this is going to make a difference to the early part of the QRS. Depolarization moves down the right bundle branch as normal, sweeps through the septum and will depolarize the right ventricle. The ventricular depolarization on the left is going to be delayed. From the blockade, the transmission has to move out into the slower myocyte to myocyte conduction, and this is going to dominate the electrical vector. The left-sided leads, such as 1 and V6, are going to show dominant and wide R waves, whilst V1 is going to show the opposite and have this great deep S wave. What we're looking at in a left bundle branch block again is obviously a wide QRS, predominant R waves in 1 and in V6, and a very deep S wave in V1. There couldn't be a rule without exceptions, and here are the various morphologies that would meet the deep S wave required in lead V1. So we may have a QS complex, so that is the start of a Q wave that goes broad and deep to form an S wave instead. Or sometimes there may be a tiny R wave that gives us an exception to the deep S wave requirement. So the clinical significance of a left bundle branch block. First and foremost, it's likely to alter the ST segments during repolarization. So it produces STEMI mimics what looks like ST elevation, but is not related to an acute myocardial infarction. It can be associated with hypertensive heart disease and coronary artery disease. And where there are cardiomyopathy and myocarditis, it's not unusual to see left bundle branch blocks as well. It can be the direct result of an acute myocardial infarction. And in the acute phase, there are ways of differentiating between a left bundle branch block of historical nature and one that's associated with ischemic changes. We have a separate presentation that's going to cover this. Generally speaking, it's considered to be the more worrying of the two types of bundle branch blocks. So we would still follow the basic heuristics of treating the patient and not the monitor, and also assuming that undifferentiated chest pain in the presence of a left bundle branch block is still going to be cardiac chest pain until proven otherwise. So this brings us to the orphan of bundle branch blocks, the one that we call the intraventricular conduction delay, or the IVCD. Now, essentially, this is a bundle branch block, but the nature of the electrical vectors make it very, very difficult to tell whether it's onto the right that's been affected or whether it's been the left. So we have this indeterminate classification. But the rules are essentially that we need a wide QRS, as is true of any bundle branch block. That it has to be a supraventricular focus for the rhythm, and that it will fit neither the pattern for a right bundle branch block or a left bundle branch block. So essentially, it's a diagnosis of exclusion. We know that the rhythm is supraventricular in focus, that a wide QRS is indicative of a conduction delay, and we can't classify it as either left or right-sided. So we give it this title, IVCD. So that brings us to the end, almost, anyway. So our recap: when assessing an ECG that's got wide QRS complexes, the differentials we should consider, first and foremost, is a ventricular rhythm. Then the historical features of the case will tell us whether there's been metabolic changes, maybe an electrolyte imbalance. Then we would consider a bundle branch block. And if that was the case, we would find out from the patient's history whether they've been caused by pacing or not. If it is a bundle branch block, our options are a left, a right, or an IVCD. And the basic rules for picking a right bundle branch block are this bimodal or biphasic R wave, the RSR pattern in V1, and that lovely, easy to pick slurred S wave, the later part of the ventricular depolarization that we see in leads 1 and V6. A left bundle branch block, it's almost the opposite pattern. So what we're seeing is dominant and wide R waves in 1 and V6 with a deep S wave in V1. With a left bundle branch block, the clinical significance is whether it's a new or an old finding. We will talk about this a little bit more. During the block course, we'll have the option to test our knowledge on a few ECGs and see if we can get these right. So in the meantime, I wish you well. Ka kite.